Good morning and good afternoon. It is truly an honor to virtually present my perspectives on the use of endogenous biomarkers to assess transporter-mediated drug-drug interactions. I would like to start by thanking the organizers for including a discussion around this rapidly emerging topic in this year's workshop and for providing me with an opportunity to present. Here is my disclaimer. The contents of this presentation are my own and do not necessarily reflect the views on or policies of the U.S. Food and Drug Administration. Also, I have no conflicts of interest to disclose. Before I start my presentation, I would really like to thank Drs. Kelly Reynolds and Xining Yang for their extremely helpful feedback on the information that I'm going to cover today. Their input really helped me put together several core concepts and streamline the presentation. Here is the roadmap for today's discussion. I will provide an overview on why transporter-mediated drug-drug interactions or DDIs are assessed in drug development, what is the typical approach of assessing transporter-based DDIs, introduce the conceptual framework around the use of endogenous biomarkers to assess transporter-based DDIs due to inhibition of transporters, and with the help of some examples, demonstrate how endogenous biomarkers can serve as an important tool and complement other available approaches to assess transporter-based DDIs. I will also highlight some current challenges and knowledge gaps related to the use of endogenous biomarkers to assess transporter-based DDIs, and then wrap up the talk with some concluding remarks. So let us start with the basic question on why transporter-based DDIs are assessed. As we all know, transporters are membrane-bound proteins which regulate the access of molecules across the cells and control the overall distribution of drugs to their intracellular site of action. Either alone or in conjunction with enzymes, transporters play an important role in modulating the absorption, distribution, metabolism, and elimination, and thereby the PK and/or PD characteristics. Hence, evaluating transporter-mediated DDIs during development and post-approval is an important part of benefit-risk assessment. In fact, various regulatory agencies also recommend the assessment of transporter-based DDIs during and post-approval. In 2018, the International Transporter Consortium, or the ITC, published a white paper to summarize their recommendations on transporters that are important to consider as part of drug development. In addition to the newly emerging transporters important in mediating DDIs, for example, the hepatic OCT1 and the intestinal and hepatic OATP2B1, the consortium members also highlighted the role of transporters in mediating drug-induced vitamin deficiencies, for example, the thymine transporter THTR2, and the involvement of OAT2 in the active renal secretion of creatinine. The figure on this slide shows the uptake and efflux transporters in various tissues. Just a few notes about the color coding for the various transporters described in the figure. The red circles represent transporters previously recommended by the ITC, and the ones which are also recommended for evaluation by the various regulatory agencies. The yellow circles, for example, the MRPs and the BSEP, are transporters recommended for retrospective mechanistic evaluation of clinical observations. The green circles, hepatic OCT1, is recommended by the ITC to evaluate whether a drug is a substrate and/or inhibitor of OCT1. The yellow square, the intestinal and hepatic OATP2B1, is also recommended by the ITC for retrospective evaluation in case of DDIs that cannot be explained by common mechanisms. The blue circles denote transporters for which sufficient evidence is currently lacking for specific recommendations by the ITC. So now let's discuss the typical stepwise approach of assessing whether a drug is an inhibitor of a transporter. So in terms of assessing transporter-based DDIs, usually a combination of in vitro approaches in silico, for example, mechanistic, static, or PBPK modeling, and in vivo, if the need is determined based on in vitro and in silico assessments, is followed. As the first step, we would typically compare the inhibitor concentration, be it dose divided by 250 ml for PGP or BCRP transporters, the hepatic inlet concentration for OATPs, or the unbound Cmax used for assessing renal transporter-based DDIs with the IC50 and compare this ratio with the cutoff. So, for example, 10 for PGP or BCRP or 0.1 for renal transporters. If this ratio happens to be below the cutoff, then no additional follow-up is needed. But if the ratio is above the cutoff value, either advanced static or dynamic, for example, PBPK modeling or a DDI trial is recommended. However, two questions often come up. One, if the ratio is below the cutoff value, does that mean significant DDIs will never be observed in vivo? And second, if the ratio is above the cutoff value, does that mean significant DDIs will always be observed in vivo? So here, the operating words be never and always. Well, the answer to both these questions is no. In the first case, we generally end up with false negatives. So this would be a case where in vitro data does not suggest the potential for in vivo DDIs, but in vivo DDIs are observed. And in the second case, we generally end up with false positives. So this would be a case where in vitro data suggests the potential for in vivo DDIs, but in vivo DDIs were not observed. In the next slide, I will present some data to further illustrate this concept. So in 2016, we conducted a retrospective analysis in which we compared the various in vitro prediction methods for assessing the potential of a new molecular entity to inhibit OATP1B1 transporters. Very briefly, what we did was we calculated the cutoff value using 6 different prediction methods as shown in the table and compared the predictions regarding potential for DDIs with the observed DDIs. So our database included 11 substrates, 61 inhibitors, and DDI data from 107 DDI studies. So it was a very robust database. As you can see in the table, no matter which prediction method we used, we always ended up with some false positive and some false negative predictions. So a logical follow-up question is that what could be some reasons for false positive and false negative predictions? So there could be multiple reasons, such as inter-system and inter-laboratory variability in determination of IC50 values, which would then affect the outcome of the various prediction methods. The second is generally only the parent form of the drug is considered, and the inhibitory properties of the metabolites are not taken into consideration. So if the metabolite also happens to inhibit OATP1B1, in this case, calculations using only the parent may not provide the complete picture. And the third, multiple transporters may affect the ADME properties of the substrate, whereas the prediction method considers only one transporter. So if the drug happens to be an inhibitor of multiple transporters, one can expect that we will end up with some false negative predictions. So with this background, let us discuss the conceptual framework for the use of endogenous biomarkers to assess transporter-based DDIs. So what are these endogenous biomarkers? In a nutshell, these are endogenous compounds which also happen to be substrates of the various uptake and efflux transporters. So the basic idea is that if we can assess changes in the disposition of these endogenous compounds after administration of an inhibitor, we can also integrate this information with the available in vitro information to better predict the potential for an in vivo DDI. The figure on this slide shows the potential biomarkers currently being explored to assess DDIs via modulation of various transporters. For example, coproporphyrins 1 and 3 are being actively investigated for assessing the OATP1B inhibitory potential of drugs. As far as renal transporters go, alterations in creatinine levels due to inhibition of renal transporters by drugs such as dolutegravir and cobicistat is well known. Regarding other endogenous biomarkers, a very recent publication in Clinical Pharmacology and Therapeutics also suggested that in addition to N-methyl nicotinamide and methyladenosine may also show some promise as an endogenous biomarker. So what could be some potential benefits of using endogenous biomarkers to assess transporter inhibition? The first potential advantage is that the effect of transporter inhibition can be assessed over a wide range of inhibitor exposures because we are assessing the PK of the inhibitor drug over a wide range of exposures early in development, as opposed to a dedicated DDI trial where only 1 or sometimes 2 doses are evaluated. And if there are early signals of transporter inhibition as assessed by changes in the levels of endogenous biomarkers, this information can be very helpful to prioritize subsequent in vivo DDI trials. In addition, information on alteration in biomarker levels can also be important to inform concomitant medication use, especially in cases where results from in vivo DDI trials are not available. Lastly, changes in the levels of endogenous biomarkers can help with mechanistic understanding of the observed DDIs and I will further discuss this point with the help of an example later in the presentation. So the concept of using endogenous biomarkers to assess transporter inhibition is definitely an important emerging and exciting area of research. In the interest of time and considering that the majority of the work in this area so far has focused on evaluating endogenous biomarkers of OATP1B transporters inhibition, in the remaining part of the presentation, I will focus on endogenous biomarkers that are being used to assess inhibition of OATP1B transporters. So the most widely used endogenous biomarkers for assessing OATP1B inhibition are coproporphyrins 1 and 3. Both CP1 and CP3 are organic anions and porphyrin metabolites of heme biosynthesis. Being organic anions, they are taken up into the hepatocyte by OATP1B1 and OATP1B3, and then there is emerging data to suggest that CP3 is also taken up by OATP2B1. They are eliminated either by urinary elimination or by biliary efflux mediated via the MRP2 and the MRP3 transporters. For the purposes of our discussion, it is important to note that inhibition of OATP1B1 transporters can increase the levels of both CP1 and CP3, something that I will discuss in more detail in the next slide. We all know that rifampin, after a single dose, is an inhibitor of OATP1B transporters, and rosuvastatin is the substrate of OATP1B and BCRP transporters. So if a single dose of rifampin is co-administered with rosuvastatin, one would expect increase in the concentration of rosuvastatin due to inhibition of OATP1B transporters by rifampin. To demonstrate this, Lai et al. Evaluated the effect of single-dose rifampin on not only rosuvastatin, but also on CP1 and CP3. So the graph in the upper panel shows the concentration of rosuvastatin as a function of time. The solid circles show rosuvastatin concentrations when given with rifampin, and the open circles show rosuvastatin concentrations when rosuvastatin is co-administered with rifampin. As expected, rifampin increased the Cmax of rosuvastatin by approximately 13-fold and AUC by 5-fold. The lower panel shows the concentration of CP1 on the left and CP3 on the right as a function of time. Rosuvastatin is not known to inhibit OATP1B transporters, hence no change in the CP1 and CP3 concentrations were noted. However, after co-administration with rifampin and rosuvastatin, the Cmax and AUC of CP1 increased by 5.7-fold and 4-fold respectively, and the Cmax and AUC of CP3 increased by 5.4-fold and 3.3-fold respectively. Overall, simultaneous assessment of changes in the pharmacokinetics of an exogenously administered known substrate of OATP1B, rosuvastatin in this case, and endogenous biomarkers CP1 and CP3 shed light on the potential role of these endogenous biomarkers in assessing DDIs mediated by inhibition of OATP1B transporters. So the next question to consider is whether the effect of rifampin on these endogenous biomarkers is dose dependent. In other words, do we expect a greater magnitude of increase in CP1 concentrations if a higher dose of rifampin is used? To address this question, Takihara et al. Explored two different doses of rifampin, 300 milligrams and 600 milligrams. As shown in the graph on the left, the effect of rifampin on CP1 is dose dependent. In addition, as shown on the graph on the right, increase in CP1 exposures after 600 milligram rifampin is statistically different from the increase in CP1 exposures after 300 milligrams rifampin. Now that we know that the levels of CP1 and CP3 can be affected by OATP1B inhibitors such as rifampin, let us explore how this information may be used to elucidate the mechanism of complex DDIs. So Jones et al. Assessed the effect of fenebrutinib, an inhibitor of CYP3A, BCRP, and OATP1B on pharmacokinetics of midazolam, a substrate of CYP3A, simvastatin, a substrate of CYP3A and OATP1B, and rosuvastatin, a substrate of BCRP and OATP1B. The authors also measured the levels of CP1 and CP3. So as you can see, the AUC of both midazolam on the top panel and simvastatin in the bottom panel increase approximately 2-fold, suggesting fenebrutinib is an inhibitor of CYP3A. Increase in concentration of simvastatin may also suggest that fenebrutinib is an inhibitor of OATP1B transporters, considering that simvastatin is a substrate of CYP3A and OATP1B. However, no firm conclusions can be drawn just by looking at this data. With fenebrutinib, the Cmax and AUC of rosuvastatin, a substrate of OATP1B and BCRP, increased by 5-fold and 2.6-fold respectively. Well, with this data, again, it is challenging to draw firm conclusions regarding the effect of fenebrutinib on OATP1B versus BCRP. This is very similar to the previous slide where it was challenging to draw firm conclusions regarding the effect of fenebrutinib on 3A versus OATP1B based on changes in simvastatin exposures. In this type of a situation, having information on the levels of CP1 and CP3 was very helpful. The graph in the lower panel suggests a lack of effect of fenebrutinib on CP1 and CP3, indicating that fenebrutinib is not an inhibitor of OATP1B transporters. Hence, the effect of fenebrutinib on simvastatin appears to be primarily due to CYP3 inhibition, and the effect of fenebrutinib on rosuvastatin is primarily driven by inhibition of BCRP transporters. And this type of assessment has important implications. For example, one may draw a conclusion that OATP1B substrates can be co-administered with fenebrutinib without any dose adjustments. And this is important to know considering there are many established OATP1B substrates. Overall, having information on CP1 and CP3 levels was helpful in elucidating this complex DDI. So in the last part of the presentation, I will outline a few challenges and knowledge gaps that still need to be further addressed before CP1 and CP3 can be fully integrated into the overall DDI assessment paradigm. The first challenge is that there is very limited clinical data to verify the performance of endogenous biomarkers with inhibitors of varying potency. The majority of the data currently available is with rifampin, which is a potent inhibitor of OATP1B transporters, but there are relatively fewer published reports on the effect of less potent OATP inhibitors. Hence, currently, it is challenging to comment on how sensitive CP1 and CP3 are to OATP inhibitors other than rifampin. The second challenge is that there is very limited data to directly compare the magnitude of changes in the level of an exogenously administered transporter substrate to the magnitude of changes in endogenous biomarkers after an inhibitor is given. In the absence of such data, extrapolating the effect of an inhibitor solely based on its effect on an endogenous biomarker becomes challenging. So in other words, if an inhibitor of a certain transporter increases the level of an endogenous biomarker by 4-fold, for example, does that mean it will also increase the levels of an exogenously administered substrate of the same transporter by 4-fold? And the third and the fourth challenge pertain to how variable are the baseline levels of the endogenous biomarkers, and what potential factor or factors can contribute to the variability. The more variable the baseline levels are, the harder it gets to obtain a good estimate of changes in endogenous biomarker levels due to an inhibitor. The last challenge is about the analytical sensitivity, considering that the systemic levels of these biomarkers are generally in the low nanomolar range. So unless we can accurately assess the endogenous biomarker levels using validated assays, drawing firm conclusions will definitely pose some challenges. So just some concluding remarks to wrap up my talk. Data is definitely emerging regarding the use of endogenous biomarkers to assess transported DDIs. Preliminary data suggests that CP1 and CP3 may play an important role in the assessment of DDIs mediated by OATP1B transporters, but there is ongoing research to evaluate biomarkers for other transporters. There are several knowledge gaps that need to be addressed to comprehensively understand the role of endogenous biomarkers in the overall assessment of DDIs. With that, thank you very much for your time and attention, and I look forward to addressing questions you may have. Thank you.